Yes, yes, ma'am. Well visible, easily moved.
Okay. Thank you, Dr. Nitin. So, jaundice, as you all know, is a common condition characterized by yellow discolorization of the skin and the sclera of a newborn baby because of deposition of bilirubin. It's a common condition affecting up to 60% of term and almost 80% of preterm neonates. But not all of them may develop pathological jaundice that may require evaluation and treatment. So, jaundice, although it is common, might still signal a serious, potentially treatable illness. If not identified and treated appropriately, it is capable of causing neurological damage, especially if bilirubin levels are significantly elevated. So, with that introduction, the learning objectives of today's presentation would be to enumerate the characteristics of physiological and try and distinguish this from pathological jaundice. To assess the severity of jaundice based on clinical or visual estimation, as well as with the use of transcutaneous bilirubin meters, and to understand where to use serum bilirubin testing with the lab. Trying to understand when to institute treatment in the form of phototherapy based on recommended national and international guidelines. And we'll try to discuss the recent updates in the AAP treatment guidelines on jaundice. And lastly, we may not be able to discuss the last part, which would be the evaluation of a neonate with conjugated hyperbilirubinemia, which is a separate topic on its own. But we'll try to at least understand what we mean by conjugated hyperbilirubinemia. So, trying to understand how common the problem is, as per the National Neonatal Perinatal Database of India, NNPD, it is said that 5% of newborns develop a serum bilirubin level of more than 15 milligrams per deciliter. So usually a bilirubin more than 15 is taken as pathological jaundice, and this can occur in up to 5% of newborns. Whereas we may see a bilirubin of more than 25 milligrams per deciliter in up to 1 to 600 or 1 is to 700 so-called well newborns. Kernicterus, however, has become pretty uncommon. And although we do not have well-developed Indian Kernicterus registries, as per the global registries, it is said that this is relatively rare with an incidence of 1 out of 27,000 well newborns. So in India, although we do not know the exact incidence of Kernicterus, it is still assumed that because of the large number of neonatal births that we have, which is up to 25 million per year, jaundice is not just common, but can be associated with complications if not identified and treated appropriately. We are all well aware of the Kramer's rule, which indicates the progression of neonatal jaundice from the head towards the palms and the soles, the cephalocaudal progression of jaundice based on the level of serum bilirubin. So, based on the assessment, visual assessment of jaundice, it can be categorized into 5 different zones. I hope I'm audible.
Yes, ma'am.
So the zone 1 indicates levels less than 5 milligrams. Zone 2 indicates levels progressing between 5 to 8 milligrams, which generally indicates the region of the chest until the umbilical. Visible staining of the palms and stools. No, you understand that levels of bilirubin may be more than 15 milligrams per deciliter. Now, physiological jaundice, as we just described, is exceedingly common among both term and preterm neonates, occurring in up to 60 to 80% of normal newborns. So, usually, physiological jaundice is recognized by the following signs. It is jaundice that appears between 24 to 72 hours of age for the first time, in contrast to pathological jaundice that can be visible within the first 24 hours of life. The maximum intensity of physiological jaundice may be seen between third day to the fifth day in a term newborn and between 5 to 7 days in a preterm newborn, and it does not exceed levels beyond 15 milligrams per deciliter. Usually, physiological jaundice levels become clinically undetectable after 14 days of life. And if you see jaundice visibly after 14 days of life in a term newborn or beyond 21 days of life in a preterm newborn, it definitely warrants evaluation with a lab test in the form of serum bilirubin with a direct and indirect fraction. So, as we understand,
Aru?
physiological jaundice does not require any treatment, and the baby should be observed closely for worsening jaundice. In contrast, pathological jaundice can be seen visibly within the first 24 hours of postnatal life. The total serum bilirubin levels may rise rapidly by more than 5 milligram per deciliter per 24 hours, or If you look at hourly basis, it may increase by more than 0.3 milligram per deciliter per hours in the first 24 hours and more than zero point 0.2 milligram per deciliter per hour later. So this equals, if you have to multiply this by 24, the average rate of rise would be more than 7.2 milligrams per day in the first 24 hours, and anything beyond 4.8 milligrams or 5 milligrams per day beyond the first 24 hours. So rapid rise of bilirubin itself may indicate a potential pathological reason. Likewise, total serum bilirubin levels crossing more than 15, which is indicated by visible staining of the palms and soles, or any conjugated serum bilirubin elevation more than 1 milligram per deciliter, or prolonged jaundice persisting more than 2 weeks in a full-term baby and more than 3 weeks, that is 21 days in a preterm newborn, may all indicate potential pathological causes of jaundice. The causes of neonatal jaundice may depend based on the period of onset of neonatal jaundice. So typically neonatal jaundice appearing within the first 24 hours could be secondary to hemolytic causes, common causes being blood group isoimmunization due to RH, ABO, or minor blood group incompatibility. Now, these require a high index of suspicion and sometimes may be relatively difficult to establish based on the lab investigations, especially in cases of ABO isoimmunization, where wherever you get a setting of a O group mother and a A or a B or AB group newborn, you may have to have a high index of suspicion for ABO isoimmunization because it may not be supported by other evidence of hemolysis in the form of fall of hematocrit or reticulocytosis or the typical peripheral smear pattern of hemolysis. Other common causes of jaundice within the first 24 hours include intrauterine viral bacterial infections, and rarely in the earlier literature you would find malaria as a potential cause of early onset jaundice. And sometimes we may see a jaundice secondary to G6PD deficiency starting within the first 24 hours of life. In contrast, the jaundice appearing after 24 hours of life can either be exaggerated physiological jaundice or jaundice secondary to polycythemia, concealed hemorrhages like Kefal hematoma, or subarachnoid bleed, suboptimal breastfeeding characterized by inadequate weight gain, sepsis, neonatal hepatitis, and metabolic disorders or inborn errors of metabolism. So, the simple rule to remember is hemolytic jaundice in newborn usually presents with pathological jaundice early in onset, usually within the first 24 hours, whereas jaundice presenting after 24 hours would generally or most often be secondary to exaggerated physiological jaundice, concealed hemorrhages, polycythemia, or because of suboptimal breastfeeding. Persistent jaundice, which is usually defined as jaundice lasting beyond the first 14 days in a term baby, can either be because of ongoing hemolysis in blood group incompatibility. We often see this in ABO isoimmunization, where newborns may keep coming back with prolonged jaundice beyond the first 14 days, but this is usually prolonged indirect hyperbilirubinemia. It may also be seen with liver diseases, congenital hypothyroidism, which is characterized by decreased conjugation in the liver, hereditary blood disorders, non-immune hemolysis because of conditions like enzyme or RBC membrane defects, hereditary spherocytosis, G6PD deficiency, or pyruvate kinase deficiency, which all might present with persistent indirect hyperbilirubinemia. Surgical causes like malrotation or intestinal atresia may be associated with increased enterohepatic circulation and may also be associated with persistent indirect hyperbilirubinemia. Now, having understood the epidemiology and the common causes of jaundice in a newborn, let's now try to understand the clinical assessment of a jaundice neonate, which includes not only the visual perception of jaundice, but also the use of accessory tools like the transcutaneous bilirubinometry. So the assessment of a jaundice neonate, the history and examination are directed towards assessing the etiology, the severity of jaundice, as well as looking for complications. So for example, when you're looking at the history, you would want to understand potential etiology or causes, like looking at the baby's blood group and the mother's blood group, asking for history of previous affected siblings with neonatal hyperbilirubinemia, the assessment for conditions like concealed hemorrhage, like Kefal hematoma, which might be palpable on the assessment or palpation of the scalp, Trying to understand the severity of jaundice by looking at the Kramer's assessment of the cephalocaudal progression of jaundice, and also trying to assess for potential complications in the form of bilirubin-induced neurological dysfunction. So, which is assessed by looking at the tone, the neurological reflexes, and looking at the sensorium of the newborn. When a neonate is clinically jaundiced, the total serum bilirubin level is at least 5 to 7 milligrams per deciliter. And as we previously discussed, the Kramer's rule and trying to assess which zone of the baby's body the serum the visual staining or yellow staining of the skin is localized to, or the maximum level of the visible skin staining of jaundice can help us understand the level of bilirubin. Now, jaundice is generally found to progress cephalocaudal direction, and this is because of the conjugation of albumin to bilirubin. It is based on the increasing efficacy of bilirubin binding with albumin. The jaundice may be restricted to the face and the trunk if bilirubin levels are below 12 milligrams, and usually when we see visible staining of the hands and the feet, the levels are more than 15 milligrams per deciliter. But one has to understand that the visual assessment of jaundice is no longer effective when the baby is under phototherapy. So, while trying to understand or assess a jaundiced neonate, the following questions need to be addressed. What is the gestational age of the newborn? And when we are talking about gestational age, we need to be very precise because the risk assessment of a jaundiced newborn would vary between a 37-week newborn versus a 38 weeks newborn. Although both may be technically considered as term, it is important for us to know the exact gestational age of the newborn. Likewise, the birth weight and the current weight, especially trying to understand the percentage weight loss from the birth weight and whether this is appropriate. What is the postnatal age in hours? Preferably within the first 72 hours, it is important to understand the postnatal age in hours to be precise. Beyond 72 hours to 96 hours, we generally would describe the postnatal age in days. Also, it is important to understand from the approach whether the baby needs further evaluation for jaundice. This is usually done in cases of significant hyperbilirubinemia or bilirubin that requires treatment either in the form of phototherapy or exchange transfusion, and trying to also assess whether the baby has already developed complications in the form of bilirubin neurotoxicity or bind. So this is assessed by a combination of clinical signs, assessment of tone, assessment of sensorium, and trying to look for the neonatal reflexes. So as we discussed, the assessment of severity of jaundice is pretty flawed based on only the clinical assessment, because a lot of studies have shown that even with senior physicians or senior clinicians, the visual assessment of jaundice based on the cephalocaudal progression of the Kramer's rule may not be 100% reliable or accurate. So unless and until the jaundice is predominantly restricted to above the chest or above the nipple line, one cannot really understand whether the bilirubin is mild versus severe. But generally, when the jaundice has not progressed to less than to beyond the nipple line, it is generally believed that the jaundice levels are unlikely to have crossed 8 to 10 milligrams per deciliter. Because of the flaws associated with the assessment of the subcutaneous staining of bilirubin, including the palms and soles, because of the variability of pigmentation in Asian versus Caucasian babies, we definitely need to look at more reliable parameters for understanding the bilirubin level. And this is where non-invasive diagnosis with transcutaneous bilirubinometers has become more and more popular. So we do have TCB or transcutaneous bilirubin meters now available from a number of companies, including the Draeger Minolta Air Shields, the BiliCheck available from Philips, and various other TCB machines, which offer multi-wavelength radiation, which is kind of reflected from the baby's skin, assessed with a spectrophotometer to understand the rough levels of bilirubin. But one has to understand that TCB meters are associated with certain limitations. Their accuracy in preterm population is, although it is shown in some studies to be reasonably accurate or to have reasonable agreement with the serum bilirubin levels, it is still not used as the traditional standard of assessment in preterm newborns in a lot of centers. And when it comes to understanding or evaluating bilirubin levels more than 13 to 15 milligrams per deciliter, TCB is often found to have poor correlation with serum bilirubin. And usually, when we see values in the TCB more than 15 milligrams per deciliter, we also advise confirmation with serum bilirubin levels. TCB can also not be used when the newborn has already been initiated on phototherapy. Although a lot of studies try to use a shielded patch of skin for looking at TCB, even for a newborn receiving phototherapy, this technique was not found to have good correlation with serum bilirubin. So once the newborn is started on phototherapy, it is strongly recommended to follow it up only with the total serum bilirubin or TSB rather than a TCB assessment. So TCB, in other words, is limited in its use in the first 24 hours of life, or pathological jaundice defined as the bilirubin levels going more than 15 milligrams per deciliter. So in both these situations, it is recommended to do TSB, and likewise in a newborn who is under phototherapy. One of the other important clinical variables to be understood for all of us practicing neonatology is to understand the risk factors for hyperbilirubinemia in a full-term unit. Now, often when we go for rounds, we are generally kind of engulfed with clinical information about multiple newborns, and we tend to actually kind of assess or evaluate all of them with the same lens when we look for jaundice levels. But this approach may not be 100% accurate, because every newborn's individual tendency to develop severe hyperbilirubinemia might be different, and understanding risk factors for developing severe or significant hyperbilirubinemia can be very, very useful for understanding which newborns really require close assessment. So some of these conditions or factors include jaundice within the first 24 hours of birth, history of a sibling who had neonatal jaundice which required phototherapy or exchange transfusion, unrecognized hemolysis, underlying history of ABO or RH incompatibility, the newborn having features of suboptimal sucking or suboptimal breastfeeding, deficiency in G6PD enzyme levels, concurrent infection, sepsis, newborns with concealed bleeds like Kefal hematomas and bruising, and certain racial predilection in the form of East Asian race or Mediterranean race. So this has generally been kind of described with the mnemonic jaundice, which indicates all the risk factors that we just discussed. The other important tool that has helped us in predicting or identifying those newborns which are at risk of developing severe hyperbilirubinemia is the Bhutanese early identification nomogram. This nomogram basically divides newborns into 4 risk zones based on an assessment of bilirubin within the first 168 days of life. So this is based on the pre-discharge bilirubin screening. This can be either done with a TCB or with a TSB. So you can either do a transcutaneous bilirubin assessment or a lab assessment of the bilirubin before discharge. And based on the baby's level, this is plotted against the postnatal age as shown in this figure. The baby is kind of categorized into 4 risk zones: the low risk, low intermediate, the high intermediate, and the high risk zone. These are based on jaundice levels falling between the 0 to the 40th centile, 40th to the 75th centile, 75th to 95th centile, and more than 95th centile, respectively. And each of these risk zones has a specific risk of developing severe hyperbilirubinemia. For example, in the low risk zone, there is 0% risk of developing severe hyperbilirubinemia, and this risk might increase to around 40% in the high risk zone, with intermediate risk proportions in the intermediary zones. So this nomogram is a useful tool for kind of screening a newborn baby before discharge to understand when they should be called back for a postnatal assessment for neonatal jaundice assessment, and can be quite useful, especially in high risk zone newborns, where you may either postpone the discharge or call the baby back for an early assessment within 12 to 24 hours post discharge. This was specially developed in the American subcontinent because it was found that early postnatal discharge was associated with a rising trend of bilirubin encephalopathy. Now, talking about bilirubin-induced encephalopathy, so this is one of the most important or most feared neurological complications of severe indirect hyperbilirubinemia when indirect bilirubin gets deposited in the basal ganglia of the newborn baby. This is generally suspected on the basis of some signs like poor tone, lethargy or decreased activity, high pitch cry, poor suck, poor feeding, and variable tone with hypo followed by hypertonia of the extensor muscles, leading to torticollis extensor posturing, opistotonic posturing, irritability, and it can also result in fever as well as seizures. In preterm neonates less than 35 weeks, the clinical features of bilirubin encephalopathy may be pretty non-specific, and the only consistent sign might be lethargy and decreased tone. Hence, it needs a high index of suspicion in the preterm gestational age. So all babies visibly jaundiced, especially below the knees, based on the Kramer's rule of progression, should definitely have an assessment of the bilirubin level, either in the form of TSB or a TCB. It's preferable to have a serum bilirubin assessment, and this must be plotted against the AAP charts, which we shall be seeing in a moment. Now, if the value crosses the threshold for starting phototherapy, this must be done. And it is always better to use a nomogram, the Bhutanese nomogram that we just saw, to do a pre-discharge screening to understand when the newborn should be called back for the follow-up. It is very, very important to ensure that the decisions for starting phototherapy or exchange transfusion or any form of treatment for jaundice are made strictly based on the total serum bilirubin level plotted against a standard chart like the AAP chart or the NICE nomograms, and are not based on individual decisions of the clinicians. Now, of late, we are also using transcutaneous bilirubin levels for understanding whether the baby needs phototherapy. So TCB, especially if it is not following under the limitations that we earlier discussed, like less than 24 hours, or the levels being much above the 95th centile, can still be used for making a decision on starting phototherapy. However, it must be followed up with a serum bilirubin after the newborn has been initiated on phototherapy to look at the follow-up or the rate of decline of bilirubin. It is also recommended that a TSB measurement may be considered if the TCB value falls right on the borderline range. So, for example, if it falls within 3 milligrams per deciliter of the phototherapy treatment threshold for any newborn with a certain gestational age and other risk factors, as in the AAP charts, then again the serum bilirubin is ideally recommended. Now, babies who develop significant hyperbilirubinemia that require treatment in the form of phototherapy or exchange transfusion must definitely have some evaluation. This is done in the form of blood groups of both the mother and baby to understand whether there is RH or ABO isoimmunization, G6PD levels. Although this is an X-linked recessive condition, it is recommended that G6PD is done both in male and female newborns because of the variable expression or the random lionization in female newborns. We also would recommend the direct COM test, especially if there is a setting for ABO or RH incompatibility. A TSH screening is definitely recommended if it has not been already done as a part of the newborn screening at 48 hours. And you may also consider getting a hemoglobin or a hematocrit to see if there is a rapid fall in the hemoglobin levels. So far we have discussed the clinical assessment of severity of jaundice based on visual assessment, TCB levels, and where we need to get the TSB levels. And we have also looked into the associated evaluation into the etiology of jaundice in the form of other evaluation. And we also understood something about the risk assessment of an individual baby developing severe hyperbilirubinemia. So let's now proceed to the management of jaundice or the treatment. The treatment of jaundice is strictly a gestational age dependent entity. So, for newborns born at 35 weeks gestational age or higher, the management of jaundice is directed towards reducing the level of bilirubin as early as possible and preventing CNS toxicity. So, in terms of prevention of hyperbilirubinemia, one of the most effective strategies is early and frequent breastfeeding. There is no role for routine formula feeding or formula supplementation merely for the purpose of prevention of hyperbilirubinemia. It is also important to identify risk factors and have a risk factor based assessment for significant hyperbilirubinemia. And if there is underlying jaundice, one needs to identify the risk factors which may predict the risk of hyperbilirubinemia associated neurological toxicity or bind. The reduction of jaundice is definitely achieved by giving either phototherapy or exchange transfusion. So these again are the risk factors that we have already discussed. Now, before we go to the treatment of jaundice and the AAP nomograms, we need to understand the risk factors for developing bind or bilirubin encephalopathy. So these are different from the risk factors for jaundice itself. So there are multiple risk factors we discussed for the development of severe hyperbilirubinemia, such as a setting for hemolysis, some racial factors, but not all of these are necessarily risk factors for bilirubin neurotoxicity. Some typical risk factors may increase the predisposition of a newborn to develop bind, and these include gestational age is less than 38 weeks, hypoalbuminemia defined as albumin levels less than 3 grams per deciliter, the presence of isoimmune hemolytic disease, that is, direct KIMS positive hemolytic anemia in a newborn with ABO, RH, or minor blood group isoimmunization, the presence of G6PD deficiency or other hemolytic conditions, concurrent sepsis, significant lethargy, significant clinical instability in the previous 24 hours. This may be in the form of recurrent apneas or blood culture positive sepsis, need for mechanical ventilation, any newborn with significant metabolic acidosis. So these are typical risk factors for the displacement of bilirubin from albumin binding and for the penetration of bilirubin across the blood-brain barrier. And these are specifically considered risk factors for developing bind. So these are important to identify because these can bring down the threshold of treatment of jaundice from the medium to the low risk zone or from the high risk to the medium risk zone. Coming to the treatment per se, phototherapy has remained the most conventionally practiced therapy for treating jaundice. So phototherapy, as you all know, is providing the newborn baby specific wavelength of light using special blue tube lights from the Philips TL52 lamp or special blue CFL lamps, compact fluorescent lamps, or fiber optic blankets versus the older generation halogen lamps to provide phototherapy with an effective wavelength or at the blue-green spectrum. Usually, this is considered taken as a wavelength of between 450 to 470 nanometers with a minimum irradiance of at least 10 to 15 microwatt per centimeter square per nanometer, but the ideal irradiance being at least 30 microwatt per centimeter square per nanometer. The higher the radiance, better is the effect. And we also have super LED and newer generation phototherapy lamps, which can emit as high as 70 to 80 microwatt per centimeter square per nanometer. The fiber optic phototherapy devices are generally, they are available in the form of Billy blankets. They're usually considered to be less effective than conventional phototherapy, and generally these are recommended in combination with conventional phototherapy. But however, they may have some advantages such as less interference with the infant care, such as bonding with the mother and continuation of infant feeding and regular nursing care practices, and they have definitely less impact on the mother-child bonding. Now we have newer phototherapy units in the form of the gallium nitrate blue light emitting diodes or the LED lamps, which are associated with some advantages such as higher spectral irradiance, as effective as the conventional phototherapy, or maybe even higher. And these are more readily acceptable because they do not cause much disturbance to the healthcare providers or the nurses taking care of these newborn babies. Moving on to the adjuvant therapies, intravenous immunoglobulin has been assessed in at least 3 moderate quality trials in term or preterm infants with blood group isoimmunization due to RH or ABO. They were found to definitely reduce the need for exchange transfusion with a relative risk of 0.28 and the number of exchange transfusions per baby. However, this would be only recommended for KIMS positive immune hemolytic anemia with serum bilirubin levels crossing or nearing the exchange zone. Okay, the other things that the neonatal community has been trying in an attempt to avoid exchange transfusion include intensivizing phototherapy by targeting spectral irradiance levels more than 30, and some studies have looked at fluid supplementation. So there is evidence from RCTs conducted at PGI Chandigarh where newborn babies with high serum bilirubin levels with concurrent dehydration, especially in non-hemolytic hyperbilirubinemia in gestational ages more than 35 weeks, were managed by giving IV rehydration with a special formula calculated as 50 ml per kg plus maintenance fluids over a period of 8 hours. So the maintenance fluid for that period of duration of 8 hours is added with 50 ml per kg, and this fluid rate is given intravenously in order to overcome dehydration And this has been evaluated along with continued oral feeding in comparison with merely giving effective phototherapy in an attempt to reduce the need for exchange transfusion. And this indeed has been found to reduce the need for exchange transfusion significantly. But note that this may be only useful or recommended in more than 35 weeks neonates with non-hemolytic severe hyperbilirubinemia with definite clinical evidence of dehydration. The AAP guidelines have been revised once in 2001 and again in the year 2022, and they give nomograms for the management of neonatal hyperbilirubinemia. And they also help us in identifying certain specific risk factors that predict bilirubin encephalopathy, where we need to be more cautious or we may actually use lower cutoffs. So it is important to identify or have a clinical diagnosis of G6PD deficiency in order to understand whether the baby actually has that risk factor. And we may often not be aware of this at the time that we start phototherapy. There may also be some rarer associations like the Gilbert gene or other familial conditions which may have association with unconjugated hyperbilirubinemia. And these are some of the practical challenges of adapting the AAP guidelines. So, the importance of having liberal guidelines from one country to another is fraught with danger because there could be differences in epidemiology, sociology, and healthcare delivery systems between countries, which may not be adequately reflected in one single guideline. However, most of the Indian or the Asian subcontinent continues to follow AAP or the NICE guidelines from the UK because of the paucity of standardized jaundice treatment guidelines from our own country. So these two charts in front of you represent the recent American Academy of Pediatrics neonatal jaundice charts. So a decision to treat with either phototherapy or exchange will depend upon the total serum bilirubin level plotted against the gestational age as shown in the chart. So each of these charts, as you can see, has lines representing the gestation age, ages 35, 36, 37, 38, 39, and more than equal to 40 weeks. And we have two different charts represented here. There is one chart for newborns who do not have neurotoxicity risk factors, another separate chart for newborns with neurotoxicity risk factors, where you can see that the thresholds are slightly lower down. So this is so important because even before you decide which chart to apply, one needs to be aware whether the baby has any of the neurotoxicity associated risk factors. Please remember that these risk factors indicate the ones which increase the risk of bind, such as acidosis, hypoalbuminemia, sepsis, significant lethargy, and not the risk factors for developing jaundice per se. So these two represent the charts for the thresholds for exchange transfusion. Again, the left side chart indicates the thresholds in newborns without neurotoxicity risk factors, and the chart on the right indicates the ones with risk factors. So far we have discussed about the management of jaundice in a newborn more than 35 weeks, where the AAP charts come in very, very handy and useful. Of course, we can also look at the NICE UK charts. How about the preterm population? So this population again becomes very tricky because most of the cutoffs or thresholds for initiating treatment in this gestational age are empirical and not strictly based on evidence. So for newborns less than 35 weeks with birth weights below 2000 grams, these are the tables that we usually follow. So based on the birth weight, you can see that you have different norms, slightly different norms for phototherapy in a healthy neonate and phototherapy initiation in a sick neonate. Again, the definition of a sick neonate is taken as a newborn with signs of sepsis, culture positive sepsis, need for mechanical ventilation, and the presence of multiple recurrent episodes of apnea or hemodynamic instability. So the thresholds also vary based on the birth weight. So you have, for example, if you have a newborn who is 1700 grams, who is relatively healthy, we may start phototherapy at levels between 10 to 12 milligrams. For a sicker newborn of the same weight, you may initiate it even at 8 to 10 milligrams. So this chart represents a flow diagram of the management of an infant, determining the post-discharge follow-up for infants who have not received phototherapy. So you may do a TCB or a TSB assessment in the newborn who after 12 hours of life, and then plot it on the hour-specific phototherapy nomogram, and you understand the risk assessment. So if the TCB happens to fall within 3 milligrams of the phototherapy threshold, as we already discussed, we should also get a TSB. If the TSB is already at or above the phototherapy threshold as per the AAP charts, you may begin phototherapy. If not, you decide the timing of discharge and the duration of follow-up based on the risk assessment pre-discharge. Now, exchange transfusion, when required, is an effective and a very reliable method to reduce serum bilirubin. However, it should only be performed if the serum bilirubin remains in the exchange transfusion range as per the AAP charts despite effective phototherapy. For newborns with Rh isoimmunization, the best choice of blood would be O negative packed red cells suspended in AB positive plasma. For ABO isoimmunization, the best choice of blood would be O group Rh compatible blood packed cells suspended in AB plasma. And in all these situations, it is also important to cross match against the maternal blood sample. Last but not the least, the management of conjugated hyperbilirubinemia for the sake of completion. This is a relatively rare condition where the newborn baby may have a direct bilirubin elevation more than 1 milligram per deciliter when the TSB is less than 5, or anything more than 20% of the total bilirubin when TSB levels cross 5. Although more and more the newer guidelines are indicating that any direct bilirubin level more than 1 milligram per deciliter, irrespective of the total serum bilirubins levels, must be considered as direct hyperbilirubinemia. So the approach to a baby with direct hyperbilirubinemia would be to answer the following questions. Is the baby born SGA? Because this can indicate a higher risk of congenital or intrauterine infections like TORCH or some certain other anomalies. Is the baby having white colored or depigmented stools? This could be an important marker of obstructive jaundice like EHPA or choledochal cyst. Is the urine high colored, and does the baby have organomegaly, liver or spleen enlargement? Hepatosplenomegaly in direct hyperbilirubinemia may either indicate the intrauterine infections or bacterial or fungal sepsis, CMV or cytomegalovirus infections, and may also be seen with genetic metabolic liver conditions like galactosemia, fructose intolerance, etc. Never ever discharge a baby with conjugated hyperbilirubinemia without attempting to find its root cause. At least there are 3 or 4 different conditions which should never be missed in a newborn with conjugated hyperbilirubinemia, which require urgent intervention. These include biliary atresia, galactosemia, urosepsis, and newborns with treatable conditions like TORCH infections. Rule out and try to establish extrahepatic biliary atresia at least within 8 weeks of life, until which time the condition is surgically correctable, and beyond which biliary atresia may predispose to structural and irreversible hepatic injury necessitating liver transplant at a later stage. And these babies are preferably managed in a level 3 neonatal unit for detailed evaluation and for immediate pediatric gastroenterology or surgical reference. So these are some scenarios where I do not know if the audience can participate and try and maybe share your responses as a message, where we would just like you to, opt what would be your preferred therapy. So let's discuss the
Ma'am,
first
do
case.
you
You're
do you
dealing with a
want me to
36.
open the mic so that anyone can unmute? I think that will create more chaos. So we'll keep it in the chat bot only.
Yeah, agree.
Okay, ma'am.
We can probably we'll ask all of them to kind of answer in the chat box. So this the first newborn is a 36 weeks newborn who does not have any of the risk factors for severe hyperbilirubinemia. And postnatal age of 48 hours, the newborn's bilirubin level is 12 milligrams per deciliter. So what would you like to do? Would you like to start phototherapy? Does this baby come under the regular phototherapy, no risk factor chart, or would you like to consider this newborn to be under a high risk factor chart? So let's just go back to this chart. Let's look at the AAP's phototherapy threshold chart. So we said this is a 36 weeker. 36 weeker is the dark red line. So the second line here. Okay, sorry, this line, 36 weeks is the second line, and we said the baby is only 48 hours old. So the cutoff for starting phototherapy in a newborn without risk factors is around 14, as per the AAP chart. So actually, you do not have to even start phototherapy in the first condition. Right? Does everyone agree? So simple. You do not have to do anything other than look into the AAP chart. Of course, you have the AAP 2001 chart, you have the new recent chart. As per the recent chart, this baby does not require phototherapy. Okay. Now moving on to the next condition, you have a 39-weeker with the risk factors of asphyxia and acidosis. So definitely these become neurotoxicity risk factors. So we discussed that asphyxia, hypoalbuminemia, severe metabolic acidosis, significant lethargy, sepsis, all these are risk factors for developing bind, right? So they would come under the neurotoxicity risk factors chart. The baby is 10 hours old with a bilirubin of 6 milligrams. So what would you like to do? Would you like to start phototherapy? Would you like to, wait? Again, simple thing. Let me go back to the AAP chart. So these are the phototherapy charts. So which chart are you going to look at now? The left one or the right chart? So definitely you would be looking at the chart on the right because this baby had neurotoxicity risk factors. Gestational age here as per this chart more than equal to 38 weeks. So you would be looking at the green line. So the baby is roughly 10 hours of life and the cutoff for starting treatment is something like 7.5. So for now, again, even in this newborn, you're going to wait. But this is pretty close to the threshold. So you may want to do a very close clinical monitoring. And wherever required, you may want to repeat the serum bilirubin levels. Yes, I agree with you. The cutoff is around 7.3. Someone has exactly written down the cutoff. Great. Okay, next scenario, 38-weeker, no risk factors, 20 milligrams per deciliter at 120 hours. So let's go back. 38-weeker, no risk factors. So this falls under the green line. We are going to look at the chart on the left because there are no neurotoxicity risk factors. The postnatal age of this newborn is 120 hours. So if you look at the newer AAP chart, surprisingly, the cutoff for starting, sorry, this is the exchange transfusion chart. This is 120 hours phototherapy chart. So what is the cutoff? Again, it's around 22. So this is one of the, I would say, relative criticisms of the newer AAP chart. So some people believe that, Indian newborns may probably end up getting managed very, very conservatively with the AAP 2022 charts. You can see that at 120 hours, this baby actually gets away without phototherapy despite a value of 20 milligrams per deciliter. But if you're a strong follower of the AAP charts, this is what you probably would do. But again, the word of caution here is before you certify that the baby does not have no risk factors at all, one needs to be 100% sure. So if you remember, even conditions like G6PD deficiency or the serum albumin levels were needed for understanding that there are no risk factors, which we don't even do when we do the first bilirubin screening. Like if you see the baby in your OP on day 5 at 120 hours and you find that the bilirubin is 20, you don't actually know whether the baby is G6PD deficient or hypoalbuminemic. So this becomes one of the flaws of the chart. You don't really understand whether the baby has risk factors or not. And this is one of the reasons a lot of Indian neonatologists would actually consider most babies to have, risk factors unless otherwise proven. So this approach also may not be found to be is not really wrong. Now, if you had to put it on the chart on the right with one or more risk factors at 120 hours, 38 weeks baby with a bilirubin more than 19, you would treat. So it's all about knowing for sure whether there were risk factors versus not. Okay, let me go straight to the last scenario. A 36-weeker with OB incompatibility at 30 hours with bilirubin of 22. So for this, I think you don't even need to look at the chart. I think hands closed, eyes closed, we may have to start phototherapy. Let's still cross check. So 36 weeker, 30 hours old, this would be obviously under the bilirubin risk factor, neurotoxicity risk factor, because this is ABO isoimmunization. Any severe hemolytic jaundice would automatically take you to the risk factor chart. So 36 week, 30 weeks, 30 hours, red line. Yeah, anything more than 12, you would start phototherapy. But when you see such a high number, do also look at the exchange chart. Now, if you look at the same baby, 36 weeker at around 30 hours with neurotoxicity risk factors, you see the exchange cutoff itself is 18. So in this baby, last scenario, you not only would start intensive phototherapy, but you will have to keep blood ready for exchange transfusion, assess the baby closely for bind. If the baby has any features of bind, you actually have to do exchange right away. And even otherwise, based on this value, you actually should be going ahead with bind with the DVET. But in most centers, it might take around 2 to 3 hours for us to arrange blood of the certain volume and compatible with the blood groups of the baby and the mother. So usually by this time, you would have assessed one more serum bilirubin value after giving 3 to 4 hours of intensive phototherapy. So if your baby does not have any features of bind and the value is declining to less than exchange cutoff, which we just saw in the chart was around 18 to 19, then you can safely withhold DVET. If not, you would be proceeding with DVET. And if there are any features of bind, no matter what, you still will have to do a double volume exchange transfusion. Right. So I think I'll stop here, and if there are any questions, we can take them, and I'll hand over back to Dr. Nitin.
Ma'am, there are no questions, but I think to do justice to topic like this, there is no one better than you. And thank you for having such an interactive session where real world scenarios and real clinical applications are taken care. I have few questions in my clinical practice, and I would like to share over here. As a
Sure.
usual scenario, we come across breast milk jaundice at 13, 14 weeks, 13, 14 days. And how are you counseling mothers at the time of discharge for a term child so that incidence of breast milk jaundice or feeding related problems can be avoided? Because in my opinion, these are completely avoidable situations where good counseling or a robust document to guide them will help.
Yeah.
As I did the research, there is some document which I am going to share with you. It is developed by National Health Mission. Wonderful document in collaboration with UNICEF, where they go pictographic representation of latching, how to keep the nipple, and once we agree, I think your opinion will be very important in that aspect. If we can do that drive, or till now, how are you in your practice are counseling your patients, ma'am?
I think excellent question, Dr. Nitin, and thank you for bringing it in. Breast milk jaundice as an entity different from breastfeeding jaundice should definitely be recognized by all of us, neonatologists or pediatricians managing normal newborns. So breast milk jaundice, as you rightly pointed, is a condition you often see in well thriving newborns. So these are newborns who are on adequate breast milk, who are feeding well, who have there are no latch issues, who are thriving well, who have adequate postnatal weight gain. Like you may find that the weight has crossed birth weight by around 10 to 12 days. The baby has started gaining weight at 20 to 30 grams per day post regaining birth weight. But these babies continue to have persistent indirect jaundice, which is usually this is a diagnosis of exclusion. So after you have worked up for hypothyroidism, G6PD deficiency, evidence of hemolysis, or Rh-ABO blood group isoimmunization, you still find indirect hyperbilirubinemia, which you believe is probably because of the inhibitors to conjugation present in breast milk. This, as an entity, is different from breastfeeding jaundice, which we see in babies who are on exclusive breastfeeding but who are not thriving well. So these are babies who are on breastfeeding, but they may have latch issues, they may have poor suck, they may have inadequate, let down reflex from the mothers. There might be primarily conditions like hyperprolactinemia leading to inadequate milk synthesis. And these are babies who have prolonged or excessive postnatal weight loss and who take long time to regain birth weight and who end up having prolonged unconjugated hyperbilirubinemia due to an increased enterohepatic circulation in the absence of adequate feeding. So the treatment is obviously different in both these scenarios. In breastfeeding jaundice, the second scenario we discussed, the important the measure would be to actually improve feeding, because the when the feeding improves, enterohepatic circulation increases, and hence the excretion of bilirubin from the body becomes better. So this requires good clinical assessment of weight gain, assessment of urine output, and other signs of dehydration, and good feeding advice. So one would look at various scales like the latch score. If you're comfortable with latch score, you can use that for assessing whether the mother and the infant dyad require any kind of additional lactation assistance. And in scenarios where, despite all these measures, breast milk is consistently inadequate, then we may have to look at replacement feeding as a solution. On the other hand, in breast milk jaundice, the problem is not inadequate feeding, but it is the presence of inhibitors to bilirubin conjugation present in breast milk. People also believe it is because of pregnandiol in the breast milk, beta pregnandiol, which is a inhibitor to the UDP glucuronide transferase enzyme that adds glucuronic acid to bilirubin. Now, this being a diagnosis of exclusion, once we have ruled out all other causes of hemolysis, one needs to actually kind of do diligent monitoring. Unless and until the levels in breast milk jaundice cause, let's say, levels of more than 20 or 22, nearing almost exchange zones, it's not recommended to stop breast milk. That is the most important, precaution. We don't advise them to go for formula feeding just because of breast milk jaundice. In view of all the other benefits of breastfeeding, it is still recommended that one continues breastfeeding with, of course, close monitoring. Most infants with breast milk jaundice do not really go until the exchange transfusion. They can be simply managed with adequate, monitoring, and over time, over maybe 6 weeks, 10 weeks, as long as 12 weeks, bilirubin levels tend to decline.
There are
I
two
hope that
questions, ma'am.
answered the question.
Yes, ma'am,
Yes.
absolutely it answers. There are two, three questions. First is role of IVIG once given IVIG as DCT is positive. And
So IVIG, yes, IVIG is usually reserved for KIMS positive immune hemolytic jaundice. So not for every hemolytic jaundice, you must have evidence that it is immune hemolysis, as different from hemolysis due to, say, a condition like G6PD deficiency. So you should have categorical evidence of either ABO or RH isoimmunization. Usually the problem is in ABO, you don't even get DCT positivity because these are IgM class antibodies. So this is a more tricky scenario where you would look at peripheral smear evidence of spherocytes, etc., as conjugate markers of ABO isoimmunization. Now, is IVIG kind of something which is strictly recommended? We did look at the Cochrane review, if you remember, if you recall, where we read that there is a number needed to treat of around 3 newborns. Like if you give IVIG in 3, you can avoid exchange transfusion is 1 in 1 newborn. Now, although this is what the evidence says, most of the institutes, including PGI and AIMS, are now kind of slowly moving away from the practice of giving IVIG because of its adverse effect profile, the risk of anaphylaxis, volume overload, and with very limited evidence that it actually avoids exchange transfusion, because you saw there were only a handful of studies with maybe around few hundred of newborns that were kind of randomized. And nowadays, with the advent of excellent fetal medicine or antenatal interventions for RH and ABO isoimmunization in the form of uterine transfusions, the need for aggressive IVIG replacement post delivery is found to become lesser and lesser, because in most of these newborns that are managed with IUTs antenatally, both the antibodies and antigens are removed substantially. So I think the role of IVIG, although established in literature, is coming down. The next question is, I'll take up the questions myself, sir.
sure,
Is it
ma'am.
okay?
Sure, ma'am. It's okay, ma'am.
So please give pointers to catch bind clinically. I think that's an excellent question. Now, as I told you, in preterm newborns less than 35 weeks, you don't really have specific markers. So if you see a baby with severe hyperbilirubinemia, again, severe in a preterm baby could be even smaller values, even lower values. If you just see lethargy, decreased tone, or some episodes of apnea, you should suspect bind. In a term newborn, Bind, unlike the hypoxic ischemic encephalopathy, the HIE related encephalopathy, bind usually tends to have a kind of fluctuating pattern of tone. So in stage one bind, you see hypotonia and poor feeding. In stage two, you start seeing increased extensor hypotonia, arching, retrocolis. You start seeing seizures at the time. And stage three, again, the baby becomes hypotonic. So it's decreased tone followed by increased tone and again decreased tone. You never let the baby go to the third phase of decreased tone, and you try to kind of identify the earliest signs would be poor feeding, poor latch, the baby becoming, hypotonic, floppy. And if you also find that the baby is deeply icteric, then you should see whether this baby is becoming floppy just because of bind. So it's likely that baby is not feeding well and looking floppy just because of bind. That would be the earliest clinical clincher. How is the motor component evaluated in bind score? So the motor component is primarily in the form of tone abnormality because, power per se is very difficult to assess in newborn babies, so are dependent reflexes, etc. So the motor component is usually assessed in the form of tone. You need a good tone assessment. So for the axial tone, you would use, pull to sit maneuver. For the truncal tone, you would use ventral and dorsal, flexion maneuvers, truncal incurvature maneuvers, and you can also look at the ventral suspension and the vertical suspension. So ventral suspension in a baby with extensor hypertonia you might actually see even a newborn baby having persistent head lifting above the plane of the body, which is actually abnormal for a newborn baby. And you may also see some degree of extensor hypotonia when you try to make the baby lie supine, where there is persistent angulation at the level of the baby's neck, posterior neck. So that's about it. So the first to come would be hypotonia, and later you would have hypertonia. So correlation of constipation the first week with jaundice. So I think by constipation, what we actually mean is decreased frequency of stooling. I mean, constipation as an entity is uncommon in newborn babies like hard stool, but yes, decreased frequency of stooling. So when you see this, you either think of conditions like surgical conditions like Hirschsprung disease or intestinal atresia, which are of course less common, where you still may have jaundice because of enterohepatic circulation. But much more common, I would say, in a baby with decreased frequency of stooling is merely inadequate feeding. Commonest reason for decreased stooling is inadequate feeding. And yes, this has a strong correlation with the development or rapid increase in neonatal bilirubin. Is there any evidence for the use of aluminium reflectors? Aluminium reflectors, this I'm not really sure. Most of your phototherapy lights, they are made of gallium nitrate crystals. I think you're talking about those silver foils, the reflectors that we put around the phototherapy devices. There was one study from AIMS that looked at these reflector foils, and it did not really increase the efficacy of phototherapy lights. Very often people try a white color cloth around the phototherapy lamp. This is again not a practice which is strongly recommended. It is believed that this white cloth will reflect the light onto the baby. But again, although these are all measures that are used, especially in CFL lamps, this white cloth may sometimes cover the fan. And covering the fan can be more of a problem because it can lead to heating of the bulbs. So, aluminum foils, no harm in using, but evidence doesn't strongly recommend its role in terms of increased efficacy of phototherapy. Should cord blood be taken to know the baby's blood group to rule out ABO RH incompatibility? Yes. So in RH incompatibility, like when you know that the mother's blood group is negative, yes, we do use cord blood. We also send a cord blood group of the baby, and we also do a direct KIMS test. If you already know that the mother is isoimmunized, so if there was antenatal evidence, ICT was positive, indirect KIMS test in the mother was positive, or she had some evidence of fetal anemia, like elevated MCA peak systolic velocity, cerebral artery peak systolic velocity in the fetus, or if she had undergone intrauterine transfusions for RH isoimmunization, then you also look at the cord bilirubin and cord hematocrit to decide whether the baby needs treatment even based on the cord levels. Otherwise, in a regular RH negative mother who does not have any such history, the regular RH negative pregnant mother that we see, it's enough if you just do cord blood group of the baby and the direct KIMS test. That's all you need to do. We don't routinely do cord blood grouping for a O group mother because not so common. But again, if the baby develops very early jaundice, like jaundice within 24 hours, or severe hyperbilirubinemia anytime in the neonatal age group in a O group mother, then these are scenarios where we also do the direct KIMS test even in ABO isoimmunization. But DCT rarely comes positive in ABO for two reasons. The A and the B antigens are sparsely distributed in the red blood cells. So, unlike RH, where the RH antigen is only present on the RBCs, the AB antigens are present in a lot of other tissues. So, the KUMS positivity is not easily seen with ABO isoimmunization. Also, because the antibodies are not the IgG class antibodies, which are readily transplacentally transmitted, but IgM class. Until what day of life is the preterm cutoff applicable? So preterm cutoffs are generally applicable for a baby born with a gestational age less than 35 weeks. So supposing you have a baby who is born at, let's say, 33 weeks, the preterm cutoff is obviously taken, and then you have day-wise, postnatal day-wise norms in the preterm chart. So you have a AAP. I wouldn't say it's a figure, but you have a table actually, a AAP preterm table. So there is a separate publication which says AAP phototherapy thresholds for newborns less than 35 weeks. Sometime in 2013 or so, this was published. You can search it on PubMed and retrieve the full text. So it doesn't have a figure, but it actually have tabular norms where you can apply the postnatal age against the gestational age at birth. So it's not really until what gestational age. I mean, in terms of birth gestational age, it is below 35 weeks. It doesn't really need a post conceptional age. So I think that's it from the questions.
Ma'am, actually, for cord blood, are there any specific tests which we should send routinely?
So routine, you mean for every normal newborn, sir?
Yes, ma'am.
Cord blood. So we are definitely not doing cord blood hematocrit and the bilirubin for every baby. We are doing it only in the antenatally diagnosed isoimmunized pregnancies. Like if the mother is a multigravida, she is already ICT positive, then we are doing in the cord blood itself because we anticipate sometimes early exchange and all that. But otherwise, we only send the blood group and the direct KUMS test in a regular RH negative pregnancy. The other test is whether we should do also a TSH. TSH and the cord blood gas are the other two, controversial areas. Recently, the Indian Academy of Pediatrics, in association with the Endocrine Society, they came out with a strong, like a letter recommending that every newborn should have a cord TSH screening because of the large number of missed thyroid screenings. When we plan to do it at 48 to 72 hours, sometimes babies are discharged before it, and a lot of newborns coming from districts and peripheral setups may never come back to us for follow-up, and it just gets missed. So with this in mind, they recommended a TSH in every cord blood, which some institutes are doing. I think it's still not a standard practice across the country. The other thing is whether to do a cord blood gas in every newborn. Of course, if you strictly want to avoid any medical legal complications, it is actually very ideal to have cord blood gas documented for every baby, because you have had cases in certain parts, even within our country, where a newborn with apparently no history of asphyxia or resuscitation, etc., who went on to have cerebral palsy later, and litigations were filed about the inadequacy of delivery room resuscitation, etc. So as pediatricians, it's always good to have a cord blood gas, just to say, that the baby was born with a pH, normal pH and normal base excess at the time the baby was born, and hence that is not the reason for the subsequent neurodevelopmental disability. So these are two additional tests you may consider adding on. But with regards to jaundice, you do a cord blood group and DCT if it is a RH negative pregnancy, and if it is a iso-immunized pregnancy, you also do the hematocrit and bilirubin from cord.
One question on the chat bot is chat box is about ABO scenario. Pavan sir is asking, ma'am, if it is ABO scenario, is it not advisable to send DCT then, as it is rare to be positive?
Yeah. Yes, sir, we do send DCT when ABO setting is associated with severe hyperbilirubinemia in the baby. So if you have a ABO setting, O mother and let's say B baby, and the baby is having severe jaundice which is requiring phototherapy, let's say at 36 hours, 48 hours, then we do a DCT. Because knowing whether DCT even if it is rare, but DCT coming positive, you may consider things like IVIG. But actually, in a regular ABO setting newborn, you may not really need a DCT. We may not have to do a DCT, because if the baby never develops significant jaundice, then mere DCT positivity still does not mean anything much to us. So if a baby in ABO setting background develops severe jaundice, then yes, definitely we do DCT. But majority of the times DCT comes back negative, doesn't help us much. So Dr. Bhutani, who is an expert in jaundice, he has written a paper where he says, in a ABO setting, if you find a baby with severe jaundice, you should consider this as ABO isoimmunization. Even if you don't get any evidence from DCT, from retic count, you may not even find fall in hematocrit, because these AB antigens are, very sparsely located on the RBC. RBC hemolysis itna nahi hota hai. It only leads to spherocytic configuration because parts of the membrane of the RBC are bitten off. So you will find spherocytosis on the smear. You don't find reticulocytosis and much hemolysis. So it's a very difficult diagnosis to make. So he says any severe jaundice in a setting of ABO incompatibility must be considered as isoimmunization, must be treated aggressively unless otherwise proved. Unfortunately, DCT is not a very good test. Is it decrease in UDPT enzyme expression in preterm? Is it because of that they are more predisposed? Yes, I mean, there are multiple reasons why preterm infants are more predisposed for jaundice. One of them is the decreased capacity of the liver for conjugation, and also more enterohepatic circulation. It is also not just the levels of bilirubin, they are also much more predisposed to bilirubin neurotoxicity. So it's said that they develop bind at much lower levels as well. But there is some controversy in preterms because bilirubin is also considered as a antioxidant. So there are some papers on conservative management of jaundice in preterm babies. Very interesting concept. They believe that it's a free radical scavenger and bilirubin should not be very aggressively managed. So these are two very different thought processes. And there was a huge paper of lower versus higher thresholds of jaundice treatment in ELBW newborns based on this premise. But again, it did not show any significant difference in the long term neurological effects.
I think we will close the session. Every question has been answered and every aspect has been touched by you. And thank you again, ma'am, for taking out time after a busy schedule in the National Conference on Vaccination and still teaching us till late in the evening. It's always a
Thank
pleasure
you.
to hear and to learn every time on all the topics which are very relevant for clinical practices, ma'am. Thank you.
Thank you so much, sir. Good night.
And we will end this session, ma'am. Thanks a lot.